Good morning and welcome to the grand round of this week. And this week and next week is very particular because it is World Moisture Associated Day. And we have just thought it to be very appropriate to highlight a hidden skin condition that is actually of concern of all of us. So it is a delight for me to introduce you to my dear colleague, Dr. Elizabeth Ayello. And I think she has dedicated her life to skin problems for patients that either had containment devices or were threatened by having moisture-associated damage and the pressure injury as a result. She's a clinician for life. She is a prolific author. She is the editor of the Advances in Skin and Wound Care Journal. She is a book editor, and she is still dedicating her life in teaching the next generation in how to manage the skin and wound of a person that has any breach of skin, because that is the ultimate of respect that can be paid to a person. She has a CV that is as long as my arm, and but when she starts to talk, you will just experience that her passion is for the management of skin, the care for skin, but actually the education of the next generation to do even a better job than what she have done. And Elizabeth, worldwide, internationally, you have done a magnificent job in changing systems, in making rules, regulations that is followed by Medicaid, Medicare, CDC, and they are just looking up to you in how to manage this, because the hidden problem, because of your work, is not hidden anymore. It's a delight to have you here, and thank you that you're willing to do this grand round for us.
Maybe I should just stop there or give a wonderful introduction. But thank you very much. I think the honor is mine to be here in your celebration of Moisture Day. I have to say that in all my years in nursing, I've never been invited to speak on a Moisture Associated Day. So thank you for being a leader in this. I am from New York City, so that's just a disclosure to say is I have a wicked sense of humor. And I mean no offense to anybody, but this is the way I am, take me for what I am. So here's my objectives that I want to share with you. And I want to frame this in wound preparation paradigm, and for two reasons. First of all, this is universally applicable to all kinds of skin and wound conditions. And also, I'm one of the authors in the seminal paper on wound preparation, which actually was published in 2003. So it was a long time ago, and served as an impetus for me to meet a very important person, Dr. Gary Civil, who is co-editor-in-chief of Advances in Skin and Wound Care, and also an international educator. So I want to define what this moisture-associated skin damage or MASS is, describe the International Classification of Diseases of ICD-11 codes. And when I was working as a clinical nurse specialist, I didn't know what this was. But I'm married to an accountant, and he always says to me, it's always about the money. And codes are about the money, at least in the United States. That's how we get reimbursed. Explore the changes in ICD-11, which are applicable as the language has moved from MNSD to irritant contact dermatitis. And then most importantly, what are the implications for us because of these terminology changes, mostly in practice as well as in research and education. I do want to say that this presentation has clinical photos in here of certain anatomy of patients. So I mean no disrespect or make anyone feel uncomfortable about it. So I just want to make that warning. And this is my own thoughts. This is not representative of any associations or organizations that I am involved with. So here's the wound bed preparation paradigm, and it gives me a great thrill to tell you that this is now published ahead of print. So you could actually go to the journal website, woundcarejournal.com, and download the article, which will be in print in April. And it's been in many iterations since 2003. It was first published in Canada in 2000, but then became international in 2003. And I just want to give a shout out that the first author is your very own Disney Smart. So I think that's wonderful. So congratulations, History. So how do we define moisture-associated skin damage? So over the last probably 20 years, this term has been used as a collective umbrella term, if you will, for the kinds of moisture damage that we see most commonly in clinical practice. So certainly the problem of incontinence, which nobody likes to talk about because it's a very private kind of a problem, and people don't make it as obvious as other problems that people see. Which always fascinates me because skin is the largest organ, and yet we don't talk about when things go wrong and it has damage to it. So it has changed from IAD to irritant contact dermatitis. And why is that? Because in the field of dermatology, are there any dermatologists here in the audience? Yeah. Maybe they're watching virtually, but they have been using the language of irritant contact dermatitis for years. In fact, when this regulations changed, they said, "Oh, welcome to the world of dermatology and the terminology that we've been using." One of the problems is moisture-associated skin damage or irritant contact dermatitis may be found in the sacral area, and then the problem is differential diagnosis between a sacral pressure injury. In my country, the regulations by CMS, which guard the payment, have very strict rules, and there's a difference in payment between something that's identified as a pressure injury or moisture-associated skin damage. So it's really critical because this is a financial difficulty for hospitals. If somebody writes the wrong label in the chart that the code is going to pick up. Wound exudate leading to peri-wound maceration. And this is a great example of this was a patient from New York who was paralyzed and developed this pressure injury. And you can see the whitish grayish here is the wound maceration of the wound edges. And that's because there was a lot of exudate comes from that wound, as well as perspiration, or the non-medical word is sweat that patients will use. And typically you'll find it in skin tones, such as back of the neck, back of the knee, and under the breasts in people who have large adipose tissue, and then around people with stomas or fistulas. Those are the four types that have been around since we started using. So why does moisture-associated skin damage become a problem? And yes, it's about the urine, the stool, or a combination of both of them, or it could be other body fluids. What happens is, particularly, is we know that the skin has a massive pH. What happens is when urine or stool or moisture is on the skin, the pH is affected by it. Thicker depending upon what chemical the enzymes are in whatever fluid is moistening the skin. And once the skin goes past acid into the alkaline area, the basic, the skin becomes normal. And that's because the stratum corneum is then being invaded by bacteria that can proliferate more so in an alkaline environment. And we need to make sure that we decrease that so that the ammonia in the alkaline is not causing further damage to the skin. Now, many times patients arrive in our hospitals, acute care settings, And what happened is the initial skin assessment. And I'm so happy to have physicians here because your system is probably similar to ours. And it's the physician that takes the initial history and physical H&P, and what's written there then becomes the record that continues throughout the person initially in the hospital. And for us, because our reimbursement is based on coding, what is said, you don't have to change it later. And our government has put in 2008 that if somebody comes in with a pressure injury and it's not documented, then you own it during hospitalization and then you're penalized in terms of you don't get as much money reimbursed. So it kind of has been a mission in nurses' lives and other people's lives to get the physicians to please not write that the skin is dry and intact on the initial assessment history, but that's not true. So also in our journal, we have an article that talks about pressure injuries happening from ambulances, but that's another talk. I'm not going to talk about pressure injuries today. So this is the history and physical said in the emergency room, and I'm not picking on the emergency room, but they're the first ones that start the record. The person's skin was an elderly woman taken home, her husband was taking care of her, skin was dry and intact. This is what the skin looked like. This is not dry and intact. This is very severe moisture-associated skin damage, now called irritant contact dermatitis. And the story was that the elderly husband didn't know how to care for his wife's skin, and he was using towels in her groin area to soak up the urine because he didn't know what to do about incontinence. And he couldn't talk about it because culturally he was embarrassed that this was happening and they didn't have the right connections and supports. So we know that it doesn't take long for this to happen, for the skin to get. So here's a piece of research. This was done with 35 women where they put synthetic urine in the buttock area. And look what happens. Within 15 minutes, 15 minutes, quarter of an hour, the pH started to rise from acid to alkaline. And the other important fact is to know that once the permeability of the skin has been invaded by urine, the patient is not only uncomfortable, they have pain, they have stinging, bacteria can get into the skin, and they are at higher risk of developing a pressure injury because wet, moist skin needs less pressure and fewer forces to break down. So it's pretty rapid, and you need prompt skin protection. All right, healthcare system change. And yes, I have been involved. The government has listened to me. I don't know why, but they do, and I'm really happy about it. And I've been able to make significant changes that have helped clinicians. But I don't work with WHO, World Health Organization, and this is a significant change that happened. So ICD codes, International Classification of Diseases, are for diagnostic purposes. They record, the data is used to analyze and compare what's going on around the world in terms of morbidity and mortality. Now, some countries, such as the US, use it for reimbursement. Is that what happens here in Berlin? Is it used for reimbursement, the coding? Yes, okay, so you're from the same wave as us. Now, the interesting thing is, not all countries are using the same version of ICD, and I have to say the United States kind of was lagging behind changing to the new ICD coding version. So this is ICD 11, which is the code. US is on ICD 10. Which one are you on? 10. Okay, so you're with us. All right. So this will probably help you to tell you what adjustments have been made to 10 in a few minutes so that your coders can extract that for you. It was adopted by WHO in 2019, and it was implemented starting January 2022. And I understand there's about 35 countries that have already moved over to ICD-11. Okay, and there's a website that you could read about if you want more. So what's important? I find this really astounding that ICD-10 has about 14,000 unique codes, and ICD-11 has 120,000 unique codes. So the good news is I'm not a coder, and I'm not about to tell you what those codes are. You can talk. You should have conversations with your coders in terms of how difficult it is to be looking through the documentation. First of all, to read what people are saying and if people are using the right words so they can get you all the money you need for the good work that you're doing. It is now entirely digital, which is huge because it wasn't always in that. And that is multilingual. And it has already been translated into Arabic. So if English is not your preferred language to read, you can see the ones that are there and they're working on other ones for you. So I just pulled out this to show you that the language changed from MASD to irritant contact dermatitis, because that's the language that dermatologists use. And really, the moisture is irritating the skin, and it's better than the language we were using beforehand. I think it's going to take at least 20 years before people start really using irritant contact dermatitis, but we'll see what happens. So these are just some of the codes, just some of the codes. I wanted to give you an idea of how extensive it has become, which is amazing because it really wasn't there on 10. But the ones that are really important, you know, and I highlighted them in red, are the ones that correlate with MASD. You know, the 4 pictures I've shown you, all right? So contact with body fluids, which would include your wound drainage, incontinence from urine or feces, stoma or fistulas, and this is the first time fistulas are on there also. And I didn't go into this too much, but napkin dermatitis, I know that you have a pediatric ICU here, and just in terms of, and they use more of the British terminology here of napkins or napkins for dermatitis. Being from America, I did not know what that was. We call them diapers. So that's the code for that. So here's the same picture that I showed you. And now what I did is I put in here the codes that for ICD-10 relate to the 4 types of irritant contact dermatitis that we see. And today I'm not going to talk about stoma intertrigo, which is the other word used for moisture and skin folds. For peri-wound here, I'm going to really zero in specifically only on incontinence, irritant contact dermatitis from that. I'm just going to do a time check to see how I'm doing. So what are the implications from this monumental change in language? Well, systems have changed. And one of the first things is that we need to have correct terminology used. But I know that sometimes what I call lay language is what gets communicated across, but we can't do that. We need to use, particularly in the chart, the right words. So we need to document what caused, what the etiology is, if it's a moisture incontinence, that's what needs to be said. And the person has irritant contact dermatitis. Where on the body is it? And what are the characteristics of it? What's the color? And I'm going to show you some photos of people across the spectrum of skin tones that human beings have. Is there inflammation, edema? Is the skin intact? What do the edges look like? Are there any satellite lesions that the person might have? And always I like to start with patient-centered concerns. And for the patient, it's pain, itching, and it could also be embarrassing. So communicating with patients' feelings is really critical. And many times the first person that they're going to be meeting might be the physician that's coming to take the HMP. And I will tell you that many patients are embarrassed about incontinence. They will not be forthcoming in that information to you. So it's kind of a sensitive topic, but it's really important to raise. Now, I will tell you the words you use are important. If you say are you incontinent, because you may not understand what you're talking about. So you need to use the cultural terms that people might understand, and these will be driven by many factors. So like in my country, we will say, are you leaking? Are you leaking urine? Are you leaking sweat? Are you leaking poo? Because people understand what poo is. They're not going to understand what stool is. So we ask, or we say, are you having accidents? And we don't mean in the car. We mean you're toileting. Are you having toileting accidents? Are you soiling yourself? So you need to use a word that people would understand that are culturally appropriate for you. And then certainly we need to look at the education of what products are available, because it's all about protecting the skin, or treating the skin. So how you clean it, what products you put on it to protect it or to treat any damage that's there. Okay, so it's all about moisture. So document the correct etiology, and most of the time this gets confused between two other skin problems. Irritant contact dermatitis damage to the skin. Either pressure injury, or what the correct terminology would be is a skin tear. But I understand there are people that make up other words rather, and this is sometimes confused. Yeah. Skin feels, okay? So skin feels are something I think about when I go for a facial, but I don't do that. And am I doing something wrong? Oh, okay. Thank you. So you need to use language that is medically approved and everybody will understand being said. You want to have personal conversations about things, that's fine. But it's either skin care, pressure injury, moisture associated skin damage, and irritant contact dermatitis. So where is it located and what are the characteristics? As you see listed here, color, inflammation, edema, is the skin intact, where the edges look like with any satellite lesions, and patient-centered concerns. So in order to help introduce this change, we had Dr. Sybil and I came up with the word F. This is a mnemonic. We like lots of mnemonics. Our nurses and physicians like reminders. So we have lots of them because you can just print out this little chunk of them and then everybody follows it. And I'm going to break this down. I wanted to just show you that it can go on one little card, which is one of them. And this is published. So assess. And again, you come up with your own policies and procedures, but skin is assessed at least daily and following each incontinence episode to look for irritant contact dermatitis, what caused it, what's the skin color, and the University of Minnesota has some really nice assessment tools that you can download and use for free. It'll show you some pictures. And the skin condition, are there blisters, are there rashes, is there fungus? Are there satellite lesions? Is it open or closed? And is it eroded? Does it have an ulcer? There's a difference between erosion and ulcer. So this is just, and I know physicians know this, but it always amazes me sometimes some of the language that is used in medical record. It's not a crack in the buttock area. You notice that's not there. That word is not there, okay? So creases between the buttocks, upper right buttocks, upper left buttocks, perianal skin. So consistency refinement. This is an assessment tool that has been validated. It's from Belgium. It's the work of Dr. Dimitri Beekman and his team. It's a simple assessment tool about how to rank skin damage from moisture. And it basically is discoloration without infection, discoloration with infection, and then use signs and symptoms that go along with it. So people can use it. It's not widely adopted in the US. This is a little enabler that I put together, and actually this is going to be published soon in an article specifically on irritant contact dermatitis. Of course, diversity of skin tones using the Fitzpatrick scale, which is created by dermatologist Dr. Fitzpatrick. And just to show people how irritant contact dermatitis looks in people with the different skin types. Because unfortunately, when I went to nursing school in a galaxy far, far away, there were not a lot of photos of diversity of skin tones. And I am in New York City, and 50% of people I take care of had skin tone of either 4, 5, or 6. So I really need to learn it on the job. So one of my passions has been to spread this around so that people have the advantage that I did not have. So this is a tool from Minnesota that you can look at in terms of how rashes look with people with agent contact dermatitis. So if you need to educate your resident and your physician, this is a nice tool that you can download and use. Now, using the correct terms, erosion versus ulcer, you probably all know this, but again, when you're educating the next generation, it's important to, and I just took the diagram from the NPIAP on skin because it's a nice one, but an erosion is the loss of the epidermis with the epidermal base, so it's intra-epidermal. Whereas an ulcer means the epidermis is gone, it's lost, and you're now into the dermal or the base. But people misuse those terms all the time. So here's some clinical examples that I like to show people in terms of erosion down here. This is superficial. We still have the part of the epidermis there, as opposed to with an ulcer. Went down past the epidermis. Oops. Okay, now I'm going to go to the C, which is that you want a consistent structure. Skin regimen, the skin needs to be clean. There's lots of good cleaners out there. You do not want to use any cleaner or soap that is alkaline. You want one that is not going to change the pH from acidic into alkaline. And depending on who's doing the cleaning, you need to know that rubbing and scrubbing the skin is not a good thing to do when it's already damaged from moisture. Correct the cause of the irritant contact dermatitis if possible. That's not always. If you can't correct it, contain it. And there are lots of devices nowadays that are on the market to contain people with incontinence at stool. Just know that you need to know how to use the equipment appropriately so you don't give them a rectal pressure injuries, for example, and contain the urine. And there are newer external devices that can be worn and products. Years ago, diapers were not a good product because they kept the urine near the body, but now the newer body absorbent products actually wick away the moisture from the skin and get trapped into the product. Don't think that they're all the same because they are not. And please, we just banned pads so that they were not in our institution anymore because, first of all, people would put at least 4 or 5 on the bed so the patient was floating on all these wet masks and they were wet. And you don't want wetness next to the skin. And treat it proactively. There's lots of good products out there. Just know how to apply it, whether it's a silicone-based barrier or cream or ointment, petrolatum, zinc oxides and creams. And you don't have to scrub every inch off of these. There are also film-forming liquid acrylates that are available in spray or wipes. So certainly participating in an interdisciplinary committee so that you have a good product formula is very important. There's a superabsorbent dressings that you could use in products, and you want superabsorbent because it pulls the moisture into the product rather than it is against the skin. Traumatic injury you need to avoid, so no tapes. You don't want dressings with very adhesive backing to it that can damage the skin, and fluid lock dressings are better. So here's an example of somebody who was being managed properly. As you can see, there's an erosion up here with an ulcer, erosion span and ulcer. And this particular person was treated with a consistent regimen that people knew when to clean and did it on time with a zinc oxide product. Okay, healthcare system change, a couple or more. If you're looking at the policies, which I hope you will be, from an interdisciplinary point of view, this is a wonderful resource that's out there. It's an international best practice. And it's available. It came from Europeans. It has 21 best practice. It was proactive because they were anticipating the release of ICD 11. And Dr. Gary Sibyl from Toronto, Canada, and I would like to invite you. If you don't have any good manuscripts, we're always looking for great manuscripts. We have a very good impact factor. And we do have a relationship with the WCDT journal that we co-share certain manuscripts, and they get translated into Chinese, French, Portuguese, and Spanish. So there's a wide-reaching international audience that we have. So, in summary, this is what I want you to take away. Get the correct cause, differential diagnosis, moisture-associated skin damage or pressure injury. Is there incontinence, urinary, fecal, or dual? If available and allowed, you can use technology. Record it accurately in the patient record, describe what you're using. We came up with the amount of app because the thing is that people would identify it and do nothing about it and not have any protective skin protocol or treatment protocol. You need adequate lighting to assess the skin, particularly the higher up you go on the Fitzpatrick skin tone scale. Are there any funguses or are there any satellite lesions? Use the correct terminology. I know it's going to take time, but irritant contact dermatitis due to urinary, fecal, or dual incontinence is what's on the code. So we just have to have a language shift here. And you don't forget the patient and the family, they are a critical part of the team. They need to buy into the prevention plan. And again, how you bring up the issue of incontinence has many cultural concerns for people, because if we have somebody who's incontinent, they probably will tell you no, particularly on the first time they meet you. Protect the skin and communicate across their thing. So I would just like to say that I am personally delighted to have been invited back to the training again. I'm thrilled to meet all of you and participate in this important educational endeavor. And hopefully I have accomplished this by defining MASD as it has converted over to irritant contact dermatitis, explained a little bit about the coding. I'm not an expert talking coders. They should be on the skin and wound team, by the way, and go to the meetings, the changes that have happened, and the implications in terms of practice and research and publication. So thank you very much. Are there any questions or comments?
Just about this napkin dermatitis, would sanitary napkins, we have patients coming with long, bleeding for long, using napkins for long. Would that also be put under the napkin dermatitis?
That's a great question. I'll just repeat it in case, because I know we have people listening virtually in here. Let me see if I can go back to the big slide with that. And we're all in a learning mode in terms of all these. There it is. No, it's a big one I want. So I'm not sure where they would put this, because these are some of them. Just looking at all the other codes here.
Next.
Help me look.
Next.
It could be other specified cause. Am I going in the right direction now? Yes.
Next. Yes, there you go.
Yeah, there it is. I'm not sure what definition that moves, but they have there's an ability to ask them questions. So I would ask that question, and when you get the answer, please let me know. It could be body fluid. It could be body fluid. What I would do is sit down with your coder and look at, and then, by the way, these are only some of the codes, okay? And these are the ones that are being used in the US to really expand, because we're still on 10, and so are you. So you haven't transitioned fully over. And, but I would send an email, a query email to who and ask them. And then whatever, if they answer you, then you have your best answer. And then make sure in your policy, you know what you should be writing in the record so that you get the compensation that you so rightly deserve. Quick question.
Thank you, Elizabeth.
You're very welcome.
Thank you very much.
Thank you.
And that would conclude our session. And thank you very much to everybody who was present, everybody online, because this is a hidden problem that can cause severe problems down the line and may stay with patients for a long, long time.
Yeah.
And it is really our endeavor to make it easy for everywhere in institutions where we are either teaching, working, or can make a difference. So thank you very, very much that we could have had this.
Thank you.